Welcome to today's webinar. As the title says, we're going to discuss clinical documentation for ICD-10. You should be able to see my screen. Right now you're muted. If you have a question as we go along, write it in the chat box and we'll answer them at the end of the presentation. This is being recorded and can be accessed on the HealthPoint website. An email will be sent out early next week with instructions on how you can access it. Also, the PowerPoints will be available at that same time. I'm your presenter today. My name is Linda Parks. I am an associate professor at Dakota State University in Madison, South Dakota. I teach health information management classes, mostly business management, coding, and reimbursement classes. I'm speaking to you today in my capacity as a member of the South Dakota Health Information Management Association. SDHIMA has partnered with HealthPoint to bring you 3 webinars focused on ICD-10. This is the second webinar in this series and will specifically address documentation requirements, how to reach the more specific codes to describe the conditions you're treating. The third webinar will have an even narrower focus of coding some specific diseases seen in family practice and internal medicine practices, and look at the necessary documentation to enable you to do that accurately. Our objectives today are to assist you in identifying conditions where documentation already meets the needs of ICD-10. That will be a relief to know. The second objective is to identify conditions or areas where documentation improvement might be necessary, so you know where to focus your energies. And the third objective is to help you identify users to be educated in how to use ICD-10 and to encourage continued coder and provider training. While looking purely at the numbers, ICD-10-CM can be intimidating. However, physicians will likely only be responsible for diagnoses that cover a fraction of these codes, the clinical documentation specific to their own practices. The clinical information necessary for complete ICD-10-CM codes breaks down into 21 different concepts, and some of them will only be heavily used by certain specialties. It is much more manageable to focus on 21 new concepts rather than 69,000 codes. For example, the number of gestations or the outcome of delivery will most likely be used only by OBGYN. Other concepts such as external causes, activity, and places of occurrence details are not required by Medicare and are used mostly for data collection, so another area that may not concern you. Many of the remaining concepts are familiar. Type, as describing diabetes. Caused by or contributing factors, symptoms, findings, associated with, history of, are common to our current documentation, and you recognize them. Physicians only need to be aware of the principles needed for documentation, and you can see that these concepts are not foreign to physicians. Now, don't you feel better already? Doesn't that help to look at the changes in ICD-10 in that way? Think of just 21 new concepts. Let's look at a few of those concepts in more detail, and I think you can begin to identify those pieces of documentation that you already are doing, and then in turn, those areas where you need to do further investigation to see what your documentation is like, and if there is a need to concentrate on improving it. I want to say this up front. The physician is not expected to use coding terms. They should continue to use the clinical terms they're using right now. We don't want volumes of documentation. We're asking for good documentation. The concept of type applies to diabetes, the most common disease of the endocrine system. Remember, with ICD-9, the 4th digit is the manifestation or complication, and the 5th digit designates whether it is type 1, type 2, or unspecified as to type, and also whether the diabetes is described as controlled or uncontrolled. Using the example of the diabetic ulcer, we have instructions to use an additional code to identify any associated ulceration, but all we can show was the location of the ulcer, not the severity, which, as you know, impacts the amount of care that's required. And that's what the screen's trying to illustrate, is 9. The difference is with ICD-10. We don't designate controlled or uncontrolled, and quite frankly, did your physicians really document controlled or uncontrolled that often? In ICD-10, type 1 diabetes codes to the category E10-something, with the 4th, 5th, and 6th character describing the manifestation or complication as illustrated by this screenshot of a partial page of a coding book. As with ICD-9, we still use the additional code to identify the site of the diabetic ulcer. But with ICD-10, we can give a more detailed description of the extent of the ulcer, from skin breakdown to necrosis of the bone. I bet your physicians are already noting the severity in their office notes, so nothing new here, if they already are, and if they are not, this is something for them to be made aware of. Remember, the more detail you can document, the more detailed the code that can be applied. ICD-10 directs coders to use Z79.4, long-term current use of insulin, to identify long-term insulin use in type 2 diabetics or patients with secondary diabetes. This is not new. ICD-9 has the same instruction. The specificity here is for the identification of underdosing or overdosing of insulin due to insulin pump failure, as illustrated by this example. The patient is seen in the ER for ketoacidosis due to the failure of the insulin pump and underdosing. She has type 1 diabetes and moderate non-proliferative diabetic retinopathy. Here you see the codes, D85.614A, breakdown of insulin pump, initial encounter. T38.3X6A, underdosing with insulin, initial encounter. E1010, type 1 diabetes with ketoacidosis without a coma. E1033, type 1 diabetes with moderate non-proliferative diabetic retinopathy. As you're documenting underdosing or complications of the use of insulin pumps when your diabetic patients come in for their scheduled appointments. I'm sure you're checking the A1C levels and their insulin pump printouts and are making adjustments in their dosages or routines. So make sure you're documenting why you're doing that, if the underdosing or overdosing is because an insulin pump setting is the apparent problem. Did you notice the A at the end of the first two codes on the previous slide? These designate an initial encounter. A for initial encounter, while patients are receiving active treatment. What do we mean by active treatment? Might be surgical treatment, ER encounter, or an evaluation and treatment by a new physician. D is for subsequent encounters, after the patient has received active treatment and is now receiving routine care during a recovery or healing phase. Examples are a cast change or a cast removal, removal of external or internal fixation devices, medication adjustments, other follow-up visits following treatment for an injury or a condition. S is for sequelae, used for complications that arise as a direct result of a condition, such as scar formation after a burn. It is added only to the injury code, not the sequelae code, and the 7th character S identifies the injury responsible for the sequelae. You will find the 7th characters for episodes with injuries and poisoning codes in ICD-10. This should be an easy documentation that you're probably already doing but never had a way of indicating in ICD-9. Another concept is that of loss of consciousness, which you can designate with intracranial injuries just as you could with ICD-9. You may not see many of these incidents in an office setting, but if you're an ER physician, you're documenting the patient's state of consciousness already. If not the exact hours and minutes, then this is an opportunity for improved documentation. And here in this screen you can see it goes anywhere from 30 minutes of loss of consciousness to loss of consciousness greater than 24 hours without returning to pre-existing consciousness level and the patient surviving. The concept of laterality is new in ICD-10. With 9, you couldn't distinguish right, left, or bilateral when it comes to paired organs. And I want to make a note here, laterality accounts for a large number of those 69,000 new codes. So laterality, like this illustration here, it helps you think of those 21 new concepts in better proportion to what you're doing. Again, if you check your documentation, my guess is that you're documenting left arm, right lung, left femur, and so forth. Now the key is to apply the correct codes to match your documentation for better reimbursement possibilities in the future. While CMS isn't changing the way MSDRGs are calculated now, future changes that require more in-depth documentation are coming. We want to capture specificity now for when that change happens. If you are not doing well with ICD-9 specificity, you won't do well with ICD-10 since it's raising the bar. You may hear your physicians or administrators saying, "Our patients are sicker than the hospital down the street." They may be sicker to you, but they aren't to the payers if the documentation doesn't say so. So along that thought line, avoid using unspecified codes. Just as with ICD-9, we still want to avoid using unspecified codes, and we still have them in ICD-10. With the greater granularity, it's expected that payers will not reimburse the full rate on a code that indicates something is unspecified, and it is one of the first areas that are targeted by auditors. For example of specificity, this one, a patient presents with superficial foreign body in the left finger. Piece of glass was removed from the finger, antibiotic ointment is placed, and a band-aid is put on the finger. We have the ability to note by our code which finger on the left. So with a simple addition of the word index finger to the documentation, we can identify which finger, and the 7th code indicates the episode of care. Excuse me, I said 7th code, I mean 7th character in that code will indicate which episode of care. Coders may be tempted to take the easy route and code unspecified if documentation doesn't support more specific codes. But this is a warning not to do that. In 2 to 3 years, when you review your severity and risk scores, you will be in bad shape because you won't have any of the specificity to your codes that you need to justify a higher level or better reimbursement. This is an example of a respiratory ventilator code from a PCS that has time frames attached to them for the procedure codes. You can see the greater specificity allows coding professionals to more accurately reflect the details of the physician documentation. Again, if it's there. And again, this is procedure codes. You'll be using CPT codes still in the office setting, so you may not have to be familiar with PCS codes, but this is just an example. As I said, the physician really needs to only be familiar with the new concepts that apply to his specialty. One of the benefits of ICD-10 is the ability to track conditions over time, giving providers a more complete clinical picture to base their treatment on. A factor that physicians may have to apply to their documentation is for transitory factors in order to track the frequency of conditions. These are familiar to everyone: acute, chronic, acute on chronic, or recurrent. An example here is when the physician documents, Jane presents for a recheck for bronchitis. She states she is less short of breath when walking upstairs this week. She says the albuterol is helping her breathing. From the information, the coder can only assign J40 for bronchitis not specified as acute or chronic. However, if the provider simply notes that the patient presents for simple chronic bronchitis, the patient can assign a more specific code for simple chronic bronchitis, J410. Multiple concepts may be used in the same code in some cases. Providers need to know all the concepts they encounter most. Some codes require not only the transitory factor but also additional anatomic information. And here's an example for sinusitis. The chief complaint was a sinus problem. The symptoms include postnasal drainage, sore throat, facial pain, coughing, headache, and congestion. The symptoms are characterized as moderate to severe and are worse in the morning and evening. The examination, the intranasal examination, reveals moderate congestion and purulent mucus. The facial exam shows bilateral sinus tenderness to palpation. The impression is sinusitis. From this note, the coder would assign J32.9, chronic sinusitis, unspecified. By noting the complaint that the problem began 2 weeks ago and is constant, and the facial exam identifies bilateral maxillary sinus tenderness, the coder would be able to go to acute maxillary sinusitis, unspecified as recurrent. And here I picked up acute, but what I'm trying to show here is to add documentation to show which sinus. So rather than the facial tenderness, correlate that in your, if the physician can write maxillary sinusitis, that gets us to a more specific code. In addition, there are other instructional notes that can add more detail to a patient's condition. These are things that explain factors that can have an impact on the patient's condition and their treatment. For example, if a culture is done which specifies a bacterial organism, this is further detail to explain the course of treatment that the physician has prescribed. Another example is, did you ask if the patient's a smoker? Has he smoked in the past or worked in an industry that exposes him to chemicals? These environmental factors may help to explain a compromised respiratory system, which may change the way the physician treats the condition. But has he or she documented it? If he knows about it, my guess is the physician's treatment plan takes into account that type of information. So it needs to be documented so it can be coded. So a note here, check for causative organisms and environmental factors and make sure they're documented if it's applicable. Donna Smith and RHIT gave a presentation for the top 10 documentation issues under ICD-10, and she described the following documentation issues that she'd already witnessed in transitioning organizations. Diabetes was number 1. Injuries, drug underdosing, cerebral infarctions, acute MIs, neoplasms, musculoskeletal conditions, pregnancy, respiratory events, and all of ICD-10 PCS. So we thought this would be a good place to look at some of the specificity in ICD-10 and how it might affect you. ICD-9 features 59 codes for diabetes. ICD-10 has expanded to over 200. This sounds overwhelming, but much of this we've already reviewed, and now you know it's something you can handle because you're probably already documenting it. Things like what type of diabetes, whether or not there's an underlying condition that makes it a secondary diabetic. Are there any associated complications due to the diabetes? And the use of additional code to identify insulin use. Injuries. There's no longer aftercare codes for injuries in ICD-10. The current injury codes are used with the 7th character extension specifying the phase of healing. The term sequela has replaced the term late effect in the index. So if you're referring patients to therapy, Be sure to specify the site of the fracture and the phase of healing. Currently, if your physician is using the term status post-fracture, this is where we want you to make the change and document the site of the fracture and the phase of healing. If you're already doing it, great. If not, this is a place where you can improve your documentation. As we mentioned previously, we now have the opportunity to distinguish encounters, laterality, and specific anatomic details which enable us to use more specific codes. These are items you'll want to check your documentation for and begin the habit of including them when seeing a patient for care of fractures and injuries. What encounter is it? Initial? Was the routine healing? Non-healing? Which side? Left, right, or bilateral? What part of the bone was fractured? Distal, shaft, proximal? Did you document the type of fracture? Was it displaced or non-displaced? Again, check your current records to see how often you are already noting these details. A couple of comments on fractures. With open fractures, we have the ability to describe the open fracture according to the Costello classification system of healing, delayed healing, non-union, or malunion. So if you're in orthopedic practice, this is an area to check for what and how your physicians are documenting open fractures, and that's what we're illustrating here on this slide, the Costello classification system. Documentation for pathological fractures should include obviously the site and the laterality, but also the etiology. Was it due to osteoporosis, neoplasms, or something else? Then, of course, the encounter type that we discussed before. A thought to help with documentation here. We know that when the physician is examining the patient, is he noting if it's a current injury or the history? If they have a history of osteoporosis, are they coming in today for medication refill that relates back to a pathologic fracture? I'm guessing that this is already being documented. If not, another place for improvement. Documentation requirements for MIs not only document site, such as an anterior lateral wall, but also whether the MI is ST elevated, a STEMI or a non-STEMI MI, and then the coronary artery that's involved, and the time frame of the MI. Here we're identifying the episodes within a 4-week time frame. If you have an OB practice, I'm guessing the trimesters and the weeks of gestation are noted in your notes when the patient comes for prenatal visits. So nothing new required here. But now the diagnosis codes will identify the specific weeks of gestation, as there is an instruction to use additional code to indicate the week of gestation. What if you have a patient with multiple gestations, say twins, who goes into preterm labor and one of the fetuses is considered malposition? There's a 7th character to designate which fetus is in the malposition, fetus 1 or fetus 2. So the documentation is important here to apply the proper code because you have to identify which fetus. And another point with pregnancies records is probably something you're already documenting, and that's whether a condition is pre-existing or pregnancy-induced, such as diabetes versus gestational diabetes, or hypertension, or pregnancy-induced hypertension. As mentioned before, ICD-10-CM provides an opportunity to report details about the patient's health not available in ICD-9. Underdosing is one of these new concepts. It identifies situations in which the patient has taken less of a medication than prescribed by the physician. The medical condition is sequenced first, with the underdosing code listed as a secondary diagnosis. The additional code tells us why the patient isn't taking his or her medication. Financial reasons are a big example right now. Whatever brought them into the office or hospital is sequenced first. Since this is new, Many physicians may not be in the habit of documenting the patient's reason for underdosing. Non-compliance as the intent of an underdosing can be reported in ICD-10, which will enable support services to provide better patient care. Codes for cerebral infarctions are another category that is much more specific in ICD-10 and a possible opportunity to get more detailed documentation. Physician documentation should include severity, acuity, location, laterality, and which side is affected. Is it the patient's dominant side or the non-dominant side? And do they have any residual effects? The example here is if an occlusion of the right cerebellar artery causes cerebral infarction, the documentation must reflect that location, the right cerebellar artery, and the origin. Was it a thrombus, an embolism, or stenosis? Have you thought about wellness exams? I'm guessing that you see some patients for their annual physical exams. Medicare and many ancillary insurance providers will pay for an annual wellness exam for both male and female patients. As you know, the CPT wellness codes are billed as age-appropriate codes and are designated for new and established patients. The CPT codes for encounters will remain the same even after the transition to ICD-10. However, to select the more appropriate diagnosis code, we need clear documentation of whether or not the exam for a general medical exam was with or without abnormal findings. This is the big change here, noting whether or not the exam resulted with or without abnormal findings. The ICD-9 code V70.0 simply stated routine general medical examination at a healthcare facility. In ICD-10, the codes identify patient by age, as you see here on this screen, but also whether or not the exam resulted in with or without abnormal findings, and then we need to use an additional code to identify the abnormal findings. And the same description applies to younger patients. With well children exams, immunizations can be a large portion of the encounter. ICD-9 is very specific for which serum correlates to the specific diagnosis code. I-10 introduces Z23, encounters for immunizations, which for a change greatly simplifies the coding process. The guideline accompanies this code does tell the coder to report first any routine childhood exam and that the procedure codes are required to identify the type of immunization given. Medicare allows you to bill for an annual well woman exam for cervical or vaginal cancer screening that includes a pelvic exam and a clinical breast exam and a screening pap smear. In ICD-9, the code was for a routine gynecological exam as the reason for the encounter. ICD-10 again asks you to identify the encounter resulting in abnormal findings or not, so providers must document whether the exam is with or without abnormal findings. And if there is an abnormal finding, they should document what was found. Are you currently doing this? My guess is you already are. The old adage was, if it wasn't documented, it wasn't done. And that's still true. But to make our documentation better, we need to update this adage to, if it wasn't clearly documented, what was done. Here are a few steps that you might think about to enhance documentation as you're preparing for ICD-10 documentation for wellness exams. If your documentation is unclear, query the provider for clarity and include some tips on how to make the information more straightforward. If documentation is incomplete or falls into a not otherwise specified code, ask the provider to clarify and add the information to the record prior to submitting the claim. Queries are a bridge. Physicians talk to other physicians in clinical terms, not coding terms, and they've been taught that the medical record is a communication tool between providers. That explains, for example, when you see notations of volume overload and pulmonary edema in a cardiac patient, and you see nondescript terms, because the physician will look at that and say, oh, the patient's in heart failure. They don't always think about the fact that their documentation is used to communicate with coders. While the coder understands what the physician means with the clinical terms, they can't code the clinical condition without the diagnosis being documented in the medical record. Without the documentation, the coder can't tell the story of the patient and give the physician credit for what he or she is doing. Consider this situation. A coder knows that the physician is treating a patient for pneumonia with an antibiotic, but knowing this general clinical picture and what disease the patient has, she can't code it. However, the clinical knowledge can help coders craft effective queries to get the documentation they need. In this case of this pneumonia patient, the coder might draft a query like this: Patient A, who has a recent admission, resides in a nursing home with underlying COPD, chronic kidney disease, and is being treated with this antibiotic. Can you indicate a more specific pneumonia that's being treated? And you have some options: gram-negative pneumonia other than H. influenza, atypical pneumonia, or streptococcal pneumonia, or something other. Here the coder is laying out the clinical indications the physician has already documented. Now she wants the physician to connect the dots in the documentation for a specific type of pneumonia. We know what you're treating, just say so more specifically what you're treating. The question in the query should use the information in the medical record, and the answers should be supported by the information in the record. Queries are a way for coders to show physicians which condition will benefit from additional specificity, and can be both a communication tool and an education tool, and should be made part of the medical record. Physicians are focused on caring for their patients, so documentation improvement needs to be concrete and relevant as possible. Tell each physician what he needs to focus on based on what that particular provider does not document well enough. That will help make the change more doable as well as more relevant, and queries are one way you can do that right now. Assess your risk areas. Have a team dedicated to ICD-10 implementation. The team can assess implementation risk areas by creating a list of frequently used ICD-9 diagnosis codes. Check whether these codes, combined with CPT codes for service, represent a large percentage of your revenue. This assessment will help you establish some encounter examples. Next, the team can perform chart auditing to see whether clinical documentation is currently sufficient to report with ICD-10 codes. This can be accomplished by having the coders recode the charts with ICD-10. This can have a twofold purpose. It gives insight into what types of training your clinical and coding staff might need, and it may help also uncover deficiencies in your EHR documentation tools. If this appears to be a problem, you now have a chance to do some fine-tuning. Rather than focusing on 69,000 new codes, it's much more manageable to focus on those 21 new concepts. Keep that in mind. Direct the findings to your physicians and start dual coding all the cases going forward. Tweak queries to physicians to reflect the questions coders might be asking after October 1. This way everyone gets practice with ICD-10 before the implementation date. Then don't forget to test with your payers to see if they can receive your submissions. The team should then look at payer readiness. Start by identifying top payers. Create a list of those with the largest number of denials. Ask when your ICD-10 testing will be available. and collaborate with your payers. Collaboration is important because it allows both you and your payer to test for high-risk outcomes. So we suggest that you work smarter, not harder. Think of the risk assessment that I just described as a gap analysis. Choose records and diagnoses to look at that are your high-volume or high-dollar diagnoses, or those that you already know have some documentation gaps in ICD-9. Start here. Another tool you can use is, if you have your EHR in place, take advantage of templates with triggers to prompt you where more information might be necessary to fully describe the condition for coding purposes. But only use the triggers where you know the documentation has been a problem. Don't use it for everything, because it's a crutch that no one benefits from when it doesn't apply to every patient. We can't talk about documentation without mentioning information governance and its relationship to coding. Now is the time to address data quality and data integrity issues that before any widespread deployment of health information exchanges. Poor data quality, meaning this documentation we're talking about today, will be amplified with HIE exchanges if erroneous or incomplete or untrustworthy data or records are allowed to cascade across health care systems. Remember, that's what the health information exchanges are doing. They're sharing information from one facility to another or physician to another. So we want the data to be correct. You can't meet your patient care goals and also the business and financial goals if the precise information isn't available. How can information governance be integrated with coding? Identify all ICD data users and uses, including reports and various ways coded data will be interpreted. Evaluate existing policies and procedures to determine if your current approaches meet all the intended primary and secondary uses of ICD-coded data. It's important to strategize now about information governance prior to ICD-10 implementation so your data content that is being collected does not result in information integrity loss. To summarize, it's all about good patient care. Complete observation of all objective and subjective facts relevant to the patient condition. Documentation of all the key medical concepts relevant to patient care currently and in the future. And coding that includes all the key medical concepts supported by coding standards and guidelines. We hear the terms value-based and accountable care. Leverage ICD-10 to your advantage in a changing world of cost containment. Accurate and complete documentation and coding provides opportunities to support some things that are going on right now before ICD-10 is implemented, such as better representation of severity and risk, recognition of varying levels of complexity of conditions and care, better claim information to support automated processing and more rapid reimbursement, opportunities to reduce audit risk and exposure, improved business intelligence to support population risk management, and more accurate measures of quality and efficiency. The requirements for good documentation has not changed, but ICD-10 codes can support much better definition of the key parameters of patient care. Better data translates into better understanding of efficiency, effectiveness, and quality. Anticipate changes in payment models that will leverage the key medical concepts defined in these codes. So, any questions? I know you can do this. I know a lot of the documentation you're already doing, so hopefully talking about this today and helping you identify what you're already doing gives you a sigh of relief, and you can concentrate then all your energies on places you can identify where your documentation improvement needs to be, and we've given you some suggestions on how to find where that documentation is. So, questions. We've got a couple here. On the sinusitis issue, please explain how we're able to code to acute sinusitis, as there is no documentation of the term acute, and 2 weeks ago is not a modifying term when it comes to code assignment. We're not allowed to assume coding. You're right. Exactly. In coding, we cannot assume something that isn't documented. And I probably didn't come up with exactly the best example there. What I was trying to give you an example of was the fact that we need just a couple of changes in the documentation to better define the severity of the code, how the condition, how long it had been with the patient, how long the patient had been affected, and the fact that if we could just have the documentation of where that facial pain was over the maxillary sinuses, that gives us a way to get to a more specific code. So probably that wasn't the best example, but that was what I was trying to illustrate, was that example of specificity for the location and the duration of the problem. See, I think we had another question. Guess not. What I also want you to remind you of is that the recording and the slides will be posted on HealthPoint probably next week on their website. You'll be getting an email next week with information about how to access those and the PowerPoint slides and get CE certificates. So be watching for those emails. Also, might make a note that HealthPoint does have some review of anatomy and physiology for our ICD-10. So if your coders feel like they need to go back and review that, that is available through HealthPoint, so you might want to check on that. And I guess that's it. Thank you for attending today. Our third webinar will probably be sometime in February, and it will be on some of the more specific diseases or conditions that are seen in family practice and internal medicine. So be watching for that. And again, thank you for attending.